session 3 in Pitfalls in Bifurcation Stenting. So the first case is the role of OCT in detection and correction of a complication of provisional left main coronary stenting. And the presenter is Dr. Srinivas Bhyravavajhala.
Dear Chairman, thank you for the invitation to present at the EBC 2021 meeting. The title of my presentation is Role of OCT in Detection and Correction of a Complication by a Provisional Technique in Left Main Coronary Artery PCA. The patient is a 51-year-old diabetic and hypertensive male who presented with a history of typical angina, which was crescendo in nature, NIH a class 2 to start with and progressed soon over 15 days to class 3. The routine evaluation by ECG and Eeckhout were normal, and a diagnosis of unstable angina was made, and he was further evaluated by a coronary angiogram. And coronary angiogram revealed an ostial LAD, critical osteoproximal LAD lesion, and also a very critical distal L6 lesion. The plan was PCA, and the strategy was to stent the distal L6 first for obvious reason, and to stent LAD lesion from LAD to left main. In other words, to treat it as a provisional left main. And the strategy we adapted here is pot side pot or repot for short. Repot for short. The LAD lesion was adequately prepared, and then a 3.5 into 22 millimeters test was deployed from LAD to left main with adequate length of stent in the left main. And the diameter of the stent was chosen according to the LAD diameter. After the deployment, the left main portion of the stent was optimized by pot with 4 into 10 NC balloon. And as repot technique requires, a distal recrossing of L6 was done, and L6 ostium was dilated with a 3.5 into 10 NC balloon. And following the first part, as well as after the side branch dilatation with the NC balloon, 2 OCT runs were done, which showed a very well opposed LMCA stent after the first part, that is, before the side branch, distal recrossing into the side branch, that is LCX, and also dilatation of the L6 ostium. Before that, the part resulted in a very good opposed stent in the left main. Now, this is the repot technique, that is the pot followed by distal recrossing and an NC balloon into the L6, which was dilated there. And an OCT pullback showed a grossly malopposed stent following the side branch balloon dilatation. This malopposition was not only in the left main, but also in the proximal LAD, as the stent rendered view shows there. So how to correct this malopposition? So there are two options. Routinely, any malopposition will optimize it by pot with an NC balloon. But the uniqueness of the malopposition that occurs with repot technique is the malopposition will go beyond the carina into the distal main vessel, which is LAD here. So for us to properly correct the malopposition, the pot should be distal pot. So the left main balloon, which is 4 millimeter diameter balloon, should be put into the LAD also and dilated there. So that would result in the shifting of the carina into the L6 ostium and jailing of the L6 ostium, and also distortion of the stent across the ostium of the LCX. The other option is to do a kissing balloon inflation followed by final pot. The kissing balloon inflation will correct the malopposition in the proximal LAD, and the kissing balloon will be selected according to the diameters of LAD and L6. So there is no shifting of any carina. And also the carina will be kept in the center of the bifurcation by kissing. So the flow divider will be in the center, as well as the malopposition will be corrected by kissing balloon. And the procedure will be completed by a final pot in the more proximal location in the left main. So that's what we have done. The resolution was of this problem was by a kissing balloon of LAD and L6, as is shown in the first angiographic image, followed by pot in the left main, and that the final image shows a very good angiographic result. And this is the final OCT, which is showing a very well opposed stent in the LAD and left main. And this is the sequence of OCT images in the left main. The first one shows, this we have kept here for easy comprehension. The first image shows the well opposed stent following the first part. The second image shows grossly malopposed stent in the LMCA following the side branch NC balloon dilatation. And the last image shows, again, well-apposed stent in the left main following final kissing and the final part. So the take-home message is, the malapposition is a real complication following report. And the uniqueness of malapposition is, it is not confined to the main proximal main vessel, but it will go well into the distal main vessel. And it cannot be corrected by mere pot. The ideal way to correct this would be kissing followed by pot. The kissing will correct the malapposition in the distal main vessel, which is LAD here, and the final part will correct the malapposition in the LMCA, which is the proximal vessel. And it also illustrates the importance of imaging in recognizing this. Had we not done imaging at every step in this case, we would have missed this malapposition following the side branch dilatation. And it is better not to treat a huge vessel like left main in a provisional strategy with a report technique, because the side branch will be very huge in size, like LCX, which will require a 3 or 3.5 size balloon for dilatation. That will definitely malappose the stent from the opposite side of the vessel wall, which is LM to LAD. And better not to treat an LMCA with the report. It is better to treat an LMCA in a provisional strategy with a final kissing and final pot. And we can take to report technique in a non-LM bifurcation like LAD, diagonal, or LCX OM. The popularity of report technique is because of the ease of doing. You need not have to put two balloons like in kissing balloon, which is a little more cumbersome. Here only we need to put one balloon followed by pot. The technique is very simple to do, but the downside is the malapposition that can occur, which can be corrected only by kissing balloon and the final pot. Thank you very much.
It's open for discussion. So I give my my impression. The first one is that this is a 0-0-1-0 lesion. So the left main was clearly not diseased. The circ was a big circ without plaque inside, and the lesion was exactly 1 or 2 millimeter in the LAD. So this type of lesions, usually you have to imagine to do an IVUS, and if you do the IVUS, you don't find a lot of plaque in the distal left main because the plaque is mainly in the LAD. So when you choose your strategy, remember there is no plaque to fill the gaps. If you do a mistake in putting your stent in the main vessel from left main to the LAD, if there is usually opposite to the carina, there is some plaque. Even if you have this malapposition, you don't notice because there is the plaque to fill the gaps. But when you have this 0-1-0, you have to pay a lot of attention of the size and what you do. In this case, in particular, they use to do the pot a 4-0 balloon, but the circ was 3.54 maybe. It was bigger than the LAD, so probably 4.5 was a good pot balloon in this case based on the Murray law. So this is probably one of the reasons why the repot didn't do. The other things that you have to pay attention to is that the last recommendation for the final pot is not to go to the carina, because in a provisional stenting, if you are not exactly at the distal strut, you are in the middle, and then you go with the pot again, you do the kissing, and then you go to distal, then you recrash your stent, and so the final pot should be done proximal to the carina. So if you did the pot side, and then you detach from the other part, from the cover, from the LED roof, the stent, and then you do the correct pot, which is proximal, you have that malapposition. So the best things, I agree with, in this case, is to do pot, kissing, and final pot. For this reason, for the anatomy and for the...
Yeah, I think when you are going to side branch with large balloon, you have often deformation of the stent and malapposition on the opposite side every time, whether you have plaque or not. And I think the case here, the case can illustrate this, because they went to circ with 3.5 balloon, and this will deform the stent and will be coming back.
And it was problematic also to do the pot because the podia should not go to the distal.
My question is how popular is pot side pot? Because in our group there are guys who do it quite often. There are guys who never do it.
For example, I never do it.
Never do it
unless it is.
Maybe it's a generation problem. Yeah.
No, but for left main I don't do. Sometimes for a LAD diagonal, a small diagonal, difficult to. So I accept for a diagonal or for a marginal branch.
I mean, in diagonal you can go with 2O balloon, and you open the strut well and leave it like this, and 2O balloon will not deform 3.5 stent. Yeah, that's the main question.
Depends on the anatomy and the other. In this case, for example, it's a bifurcation 0-1-0. There was some space to do the precise positioning, and so I was guided or OCT guided precise positioning with the huge circ. The problem is that you should pay a lot of attention not to protrude to the circ because, but if there is some space sometimes.
Just a short comment. I agree that it remains controversial, pot side pot or kissing for provisional stenting. I'm sure it's a question of a generation or not. Personally, I'm really, I like a pot side pot, and I'm not totally convinced that in this case we should absolutely do kissing balloon. There are some data coming from Fine showing that the eccentricity index is really bad after a kissing balloon, and I think that you are right. The main problem here is really the size and the exact position of the balloon during the re-pot. I'm really convinced that we can have a good result in this case with a pot side pot technique.
But when do you do pot side pot? What is the best indication?
For this case, it's just an ostial LAD, as you mentioned, and if you finish the case with an appropriate re-pot with a good size and a good position, I am sure that you will have a good result in the circ.
Yeah, you're right. I agree with you. But in my opinion, this is the reason why I do pot kiss pot, is that the margin of error with the pot side pot is higher than pot kiss if you do a distal crossing and very proximal pot, because you don't go to the, so you are more safe to do. It's one step more to do the kissing, and this deformation that they say if you do it's a minimal deformation for a large vessel. I think the safety is better than the optimal circular shape of the left main.
Can I also have a remark? I think at the end they figured out the best option, but probably to start with the left main bifurcation was not a good idea for this particular patient to do pot side pot. And this is also an observational study of us that we did a lot of left main bifurcations also. But I figure that maybe if we open towards the circumflex with a smaller or undersized balloon, and that's what I would probably suggest, not to have an overstretch injury, and then do the kissing with the undersized balloon toward the circumflex, because we all know that we all generate problems 6 months, 1 year later with the circumflex osteum. So if you leave it like free of any potential harm, then probably that's the best option. So leave it like that, or maybe do pot, a good pot towards almost to the LAD at the distal left main. And if probably the circumflex looks okay, then you just leave it like that, or maybe just open with an undersized balloon and do the kissing with an undersized circumflex balloon and the correct size balloon towards the left main, and then do re-pot. And by OCT, then the images would have been somewhat better. And yes, pot side pot for this particular 0-1-0 patient probably is not the best option to start with. Okay.
Okay, I agree in part with your comment, because we have now cases with if you do only the pot without the kissing, you have this strut, especially in front of the circ, which is a big circ. You have the probability to have some intimal hyperplasia growing on the strut, on the free strut, and to have some problem in the future. So there are. I personally always perform for a left main left main LAD, the kissing, I open the strut to the stent if I can.
And probably that's the best option. That's something to consider. That's the undersized circumflex balloon. And that way you don't cause any harm or potential overstretch injury for the circumflex osteum, which we all know that's the worst part. That always the recoil and the restenosis comes after 6 months for sure.
Ivan Ilic will present this case. The title is Fractured Stent in Left Main.
Dear Chairman, thank you for the invitation to present at the EBC 2021 meeting. The title of my presentation is A Fracture in the Main. These are my potential conflict of interest. The patient I would like to present is a 68-year-old male presenting with ST elevation myocardial infarction and a chest pain lasting for 2 hours. He was previously treated for hypertension, dyslipidemia, and diabetes. On presentation, he was hypertensive and tachycardic with slightly decreased LV ejection fraction with some regional wall motion abnormalities. He had a fever 2 days ago, but he tested negative for COVID-19, and he stated that had previous renal failure. On ECG, you can notice an ST elevation in AVR lead, but also there's a striking ST depression in D1 and precordial leads. On initial angiography, there's a long calcified lesion in proximal and mid segment of the right coronary artery, but you can appreciate a critical lesion in the left main stem of the left coronary artery. More coronary angio showed that left main was stenosed in a distal segment with preserved flow and without stenosis of the ostial segment of the LAD and CIRC. We don't usually do scoring when we have a patient in acute coronary syndrome, but in this patient, right coronary artery gave 10 points and the left main 14 point, which yields 22 points in syntax 1 score. Syntax 2 stated that there's an equipoise between suggested treatment of PCI and cabbage, and the surgical Euroscore 2 yielded relatively high mortality due to urgency of the procedure and an ongoing ischemia. Recently developed syntax score 2020, which used the data from the syntax trial and another 3 trials that analyzed patients with multivessel disease, showed that there's a slightly higher mortality with PCI and MACE events compared to cabbage. And now, none of these studies have not taken into consideration patients with ST elevation myocardial infarction, and previous generations of drug-eluting stents were used, and most of them have never used imaging in the procedure. So the question is what to do with this patient. There's an option of PCI in the same procedure, or send patient to surgery, do heart team analysis, or just wait and see what will happen. We've decided to do the PCI in the same procedure, and we pre-treated patient with DAPT, used a radial access, and placed workhorse wires in LAD and CIRC, pre-dilated the left main and LAD with non-compliant 2.75 balloon, and then implanted Synergy 3.5 × 24 stent. The pop was done using 4.5 NC short balloon. And the result was relatively okay regarding proximal LAD. We used a provisional strategy, but there was a sluggish flow and an incomplete opacification in the left main, pointing towards something was not okay. We decided to do stent boost, and unfortunately, based on this image, you cannot easily discern whether this is stent distortion, fracture, underexpansion, or breakage. So we've decided to do IVUS. Despite relatively preserved lumen and diameters, there was a gross malapposition and incomplete expansion of the stent in the LAD and also in the left main. But you can also notice a very calcified lesion that takes up to 180 degrees of circumference and an incomplete apposition of the stent in the left main. We've decided to repeat proximal optimization and also to do a distal optimization with larger non-compliant balloon, and then implanted short, large diameter synergy stent 4.5 only in the proximal, in the left main, and then repeated POT with 5.0 NC balloon. We've repeated stent imaging, and as you can see that there's a well-expanded stent in the left main and LAD, and on the angio, the flow looks good and the expansion of the stent looks relatively okay. Also, in another projection, you can appreciate that the ostial segments of the circ and LAD are without significant stenosis. We repeated IVUS, the diameters and cross-sectional area were greater, and you can see that there's an optimal, or I say adequate expansion of the stent in the left main. And the patient stayed in hospital for 3 days, and he was seen 1 month after the procedure doing okay. And we scheduled repeated PCI of the right coronary artery and angiography, and probably imaging of the left coronary artery. But what has to be done now is to do a stent distortion analysis in this patient. We use Synergy platinum chromium stent, which is thin strut stent with abluminal polymer and sirolimus as antiproliferative agent. And this stent comes in various diameters, and for the large vessels, it has 10 crowns and reinforcement of 2 to 5 connectors. As in bench study, this stent can be expanded up to 6 millimeters, but what can be compromised is the radial strength and adequate scaffolding of the very calcified left main in this situation. And also, imaging in acute coronary syndrome can and should be used, because risk of using imaging is smaller than the risk from suboptimal procedure. It can be initiated at any point during the procedure, but the results should be interpreted cautiously. This is my presentation, and I'll thank you for your time.
So if you have any comments?
Did you consider use the Synergy Megatron instead of the conventional Synergy? Because I have a dedicated stent for the left main with thicker struts.
Yeah, unfortunately, we didn't have Synergy Megatron at that time. We only had usual Synergy in larger diameter. Megatron was not available at the moment. I agree with you that it would, provide more radial strength and better support to calcified lesions in left main.
Maybe a short comment regarding the possible interference between your guiding catheter and the proximal struts of the stents. Do you think that you have a lot of manipulation of the guiding, and that could be a part of explanation, or not at all?
That might be the reason. As you can see, that there's a suspicion that the stent was compromised in its proximal segment. Also, it was unexpanded due to calcified nodule of the left main. But we didn't, do too much pulling and pushing with the guiding catheter. But I'm certain that it cannot be excluded as a possible cause of stent distortion.
Well, actually, I had an experience very similar to this one with the same stent. And I think that what we are seeing in bench is not corresponding to reality. When you have very calcified lesion and you go with 5.0 balloon in a 3.5, and then the result will be like this. Particularly if the stent, you have less links on the stent, in between the rings of the stent. And this is the case of synergy stent. Second, the comment about intravascular imaging. I think it depends on hemodynamic stability of patient. If you do not have stability, you cannot do anything before you are dilating, and you cannot go just to plan your procedure by IVUS or any other intravascular imaging. I think this is very crucial point in emergency situation.
I think I had the same comment on Megatron. I think it's probably a progress for the company, and the company will not tell us, but probably they were aware of this fracture, and that's why they came up with Megatron. At least I like the stent in the left main.
One short comment. Did you do IVUS before or after lesion preparation in the left main?
We did IVUS after implanting the stent from the left main towards LAD. Then we did IVUS. We didn't do it before stent implantation.
Yeah, because I think one of the reasons that, okay, Megatron is a better option for this particular patient, but synergy stent has its pitfalls maybe, and maybe the company was aware of that. And I think if the hemodynamic situation was okay, so you didn't put intra-aortic balloon pump, you didn't have to give some arterial, or then you might have to consider adequate lesion preparation, even consider maybe just a rotablation, and then I do IVUS to do measurements, and then place a stent, and then you can go, because this way you just had to run after the result, and what you saw was basically some sort of a situation created by inadequate lesion preparation. But that's just my suggestion, or at least if you have IVUS on the table, then maybe you just have to consider after lesion preparation to perform IVUS to see the results and see what are the measurements, and what are the measurements are suggesting for stent sizing.
But then the question is, imagine you have a big left main with a big eccentric calcium plaque. What is the best treatment option? I don't think we know. No. Jerry, I don't know if you want to comment, but it's not so easy. Shockwave.
Shockwave is option.
Shockwave
if the hemodynamic situation is okay, then we should consider.
In the back, yeah.
Last question.
We've also seen a couple of cases with the IVUS catheter. Actually, the IVUS catheter we have, at least, is an old bulky one, and that has actually also crushed the longitudinal length of the stent while inserting the IVUS catheter. We've had 2 cases of that, and we've never seen that with OCT of the left main. Obviously, it has other challenges, but that's one thing to be aware of, is the IVUS catheter is not necessarily your friend.
I want to add a final, my opinion, for me, is the longitudinal deformation. The angle was not favorable because it was very high left main. It was a 7 French guiding catheter. It was maybe too long. Sometimes you have to change the guiding catheter strategy to be less aggressive. When disengage the wire from the circuit, pay a lot of attention to pull this guiding catheter. So longitudinal solution. Sometimes you can solve the problem just with imaging. You image, you see where is the problem. You take your balloon, big balloon, you balloon, and you can, partially fix the problem without putting another stent. Otherwise, you have to put, as they did, another stent inside stent, which is mandatory if the after ballooning is the result. Another tip I try to use when I have this left main stents with 3 connectors or 2.5, but I had a problem with the stent with small during a kissing balloon, because sometimes you have to do a big kissing with big balloons. I use a 3.5 and 4.0 balloon, and because I was removing simultaneously, because I learned like this, the 2 balloons, probably the 2 balloons were wrapped. And when I removed the balloon, I felt some resistance, but not a lot. And then I saw the 2 wires was there. I removed, and then on the 2 balloons there was the stent. So I removed completely the stent from the left main, because this stent, just if you have, they come out, you can lose the stent in there, but I was you know, lucky because they were trapped by the two balloons, and then I extracted completely the stent.
You must have a special Y connector to get them through.
No, so it was elongated because you know, the stent, it's a long piece. I have the picture. It was 3 or 4 centimeters long. Okay, go on with the next presentation. It's OCT-guided decay crash stenting of an instantary stenosis at the LAD-D1 bifurcation. Dr. Kasturi will present the case.
Dear Chairman, thank you for the invitation to present at the EBC 2021 meeting. I am Dr. Sridhar Kasturi, Head of the Department and Senior Interventional Cardiologist from Sunshine Hospital, Hyderabad, India. The title of my presentation is OCT-guided decay crash stenting of ISR of LAD-D1 bifurcation. This is a 65-year-old gentleman, known hypertensive. He underwent multiple interventions. Presently got admitted for PCA of ISR of LAD-D1 bifurcation site under OCT guidance. Angiogram shows L6 is stents very well patent. There is a diffuse long segment lesion involving the proximal to mid LAD, and mid LAD appears to be fine, and distal to the stent there is a mild lesion. LAD, a very tight severe stenosis of the mid diagonal. You see the very tight stenosis of the mid portion of the previously stented diagonal stent. And you can see in this view, you can tight stenosis proximal to the LAD stent, and right coronary non-dominant, distally totally occluded. Then wide LAD and diagonal and pre-dilated with 1.5 balloon, and then we acquired the OCT images. The OCT image very clearly showed there is a significant plaque burden proximal to the stent. There is a severe atherosclerotic plaque with a healed plaque and a lot of lipid-rich plaque. And if you see the analysis, distal to the stent also there is significant plaque burden, distal edge stenosis due to atherosclerosis, and the remaining portion of the stent appears to be fine. And then if you see the diagonal, this is the proximal portion of the LAD. You can see there is a lipid-rich plaque, plenty of macrophages, healed previous plaque rupture, and intraplaqueal hemorrhages. You can see very nice plaque, lot of plaque burden proximally. And if you go to the classification management of ISR, is it mechanical? Is it because of the biological cause, or mixed pattern CTO or more than 2 stents? So based upon the etiology, you can also choose the treatment of choice. If it is mechanical, under expansion, mechanical cause due to under expansion, high pressure balloon, or DEB can be used, or stent fracture, replant disc, internal hyperplasia. You can do the DCB or DES or VBT. Neoarthrosis, you can treat with the DCB or DES. Or neoarthrosis, severe calcification is there, you can do the plaque modification. So it throws a light OCT. What is the mechanism of the ISR and what kind of treatment you can choose? DES, DEB, both are under class 1A group. So highly recommended. You can choose any modality. And this is a recent third report of the international DCB consensus group. What they emphasize mainly, plaque modification is very, very lesion preparation key in producing the best results for DCB. You can use the angioscope, you can use any cutting balloon, or if severe calcium is there, you can do the plaque modification with the plaque modification devices, achieve the 1:1 ratio, and still suboptimal result is there. Then you can go with the DES. If the optimal mean luminal area is there, adequately prepared without any flow limiting rejection, you can do the DCB. Even after DCB, still suboptimal result is there. If you can do the FFR result is positive, then you can go with the DES stenting. And here the study has shown very clear, more number of multiple layers of stents. The DCB results are far superior compared to DEB. Compared to DES, the DCB results are better. Here they compared 1 year MACE rate for patients who underwent more than 3 metal layer drug-eluting stents for ISR. Read-S, you see the MACE rate 57.9% versus 20% in DEB group. That means results are far better with the DEB group. Then again, pre-dilatation of the LAD, and subsequently we implanted the 2.25 into 34 resolution onyx stent in D1. We kept the 3 mm balloon in LAD to crush the stent, and the D1 stent crushing was done with the 3 mm balloon. This is the implantation of the DES in the D1, slightly extended into the LAD and crushed with the 2.5 and then 3 mm balloons. And this is the angiogram after crushing. Here we faced a lot of problem in crossing. So the crusher segment after performing the first kissing balloon is the opening of the stent studs using 1.5 balloon. You are recrossing, then you can see the first kissing, that 2.5 and 2 mm balloon, then upsize to 2.5 and 3. Here we are facing a lot of problem to cross the LAD, that crushed portion. You can see we are unable to cross here despite using the guide liner. Then what we did, we used the balloon anchoring and we tracked the guide liner over the balloon and crossed beyond the crushed segment, because otherwise this crushed segment was not allowing us to place the stent. So then we put the guide liner beyond the D1 and bifurcation stent, and you can see very clearly how we are placing. You can see very clearly after this is the dilatation, we see the guideline tip is beyond the LAD-D1 bifurcation. Despite multiple balloons, we were unable to cross. Finally, we could cross the lesion with using the guide liner over the balloon tracking method. Then we put the stent, that is 3 to 38 mm resolution onyx stent in LAD. You can see the stent is expanded very well. And again, recrossed with 1.5 balloon. And then we use a 3 mm balloon to LAD and 2.7 12 mm NC in D1. So this is the second kissing. So again, dot of diagonal was done and dot of the LAD stent was done. And you see the nicely expanded. And this is the nice part was performed with the 3 and 3.5 balloons. And you can see the OCT image very nicely. He expanded the diagonal stent, expanded the LAD stents, and the proximal LAD stent area is 8.9 square mm, 8.7 square mm. And at the bifurcation side, 10 square mm. And distally, you can see 9 square mm, and diagonal stent is nicely expanded. This is the OCT run of the diagonal. You can see the mid portion, there is significant under expansion, that is about 77% only. And you can see very clearly the LAD expansion is very beautiful and nicely expanded. And you see the LAD diagonal stent is not expanded in the mid portion. Then again, we took the 2.75. We gave a high pressure prolonged inflations because under expansion as with the high rate of restenosis rate. So if restenosis, if you want to avoid the restenosis, you should get the adequate expansion and see that the entire disease segments are covered with the stent. Bifurcation mode, you can see the nicely open D1 and side by rendering out the D1. And you can see the nicely expanded stent of the proximal LAD and mid LAD and the diagonal. And this is the D1 post dilatation with because under expansion was there, optimized with 2.75 balloon, high pressure, prolonged inflation. This is the final result. You can see the nicely expanded the proximal LAD stent, mid LAD stent, and LAD D1 bifurcation side as well as the diagonal stent. So OCT evolution ISR is needed to know the mechanism of ISR and in choosing the appropriate treatment strategy. This patient showed a significant plaque burden, proximal LAD, which is lipid-rich plaque. That's the reason it was covered with the DES. Diagonal stent was under expanded, which was expanded it well with the re-DES and optimized with the OCT. Difficulty in crossing crushed segment site of LAD was managed with the guide liner with balloon tracking. Decay stenting of LAD-D1 bifurcation was done with the optimization using OCT due to recent favorable outcome data. Thank you one and all for paying attention.
So open for discussion. See if you have any observation. I want to concentrate on the reason why they had to use a guide liner to cross the diagonal. What was the problem? What they did, because the problem was, it was a decay crush theoretically, but after crushing the diagonal, the stent didn't cross in the main vessel. What happened? What could have been happened here? I give my impression from the sequence of the my opinion. I saw they cross with a 1.5 balloon. So it was difficult to go inside because they had to use a 1.5. They didn't know where they, first of all, they have a 3.0 balloon in the LAD, but then they crash with the 2.5. So when you have a decay crash and you crash in a LAD which is maybe 3.5 proximal with a 2.5, you have the crash portion which is not opposed to the vessel. Then you go with your wire because you have to cross, and you don't cross. Maybe you are, this stent is not completely crashed, so maybe you are out, in, you don't know where you are inside. Maybe you are in the same true lumen, that you crash because it's still open. So if they enter in the true lumen with the one, and then when they post-dilated, this is another question. You should not post-dilate after crashing the balloon because they went from mid to proximal. So if they were in the true lumen, they post-dilated the stent again in the main vessel. And then they went with the stent in the main vessel, but if this stent was protruding, they had to crash again. So, but you are not able because the guide wire in the LAD, so maybe they had to re-engage the LAD. You have to pay attention where do you re-engage, maybe across a strut, then you have to go. So you have, in my opinion, in this case, when there is some problems, you should try to recrash again the side branch. Don't do with the main vessel stent, but go with another wire. Maybe you can cross the protruding stent, but you cross and you crash again, and you do a kissing if you are able to go, and then finally you go with your last stent. So it's very important to follow the rule, not to be too easy to go with this side branch stent. You should crash with.
May I comment? This patient actually, I'm Dr. Sridhar Kasturi. Initially, we did 2.5 and we found the difficulty. We upsized with 3 mm balloon. Then even 3.5 was used to crush the stent. We know once the inadequate crush is there, the struts will project to the lumen. So wire may go through the struts. It's very difficult to cross. Then we realized we underestimated the size of the vessel. Then we crushed with the 3.5. Subsequently, then we could cross with a guideliner. So we anticipated the crush was inadequate. Then upsized with 3 and 3.5 balloon.
Yeah, you did the right thing, but this is just for a teaching point of view from your presentation. We did understand what you did exactly. Just from the learning point is that you should crash the stent probably with a balloon that you use for the pot, not for an undersized balloon. This is the message.
Can I come in that there's a question from our colleagues online that. Was it clear what the original stenting strategy had been? Did you have the procedure details from the original strategy?
Yeah, based upon image, because proximal to the previous stent, there is a significant plaque burden, healed plaques were there, lot of plaque burden. So proximal to the stent, there is not much plaque burden. Inside the stent, there is no resistance, but distal to the LAD stent, there is a plaque burden and edge atherosclerosis is there. And the proximal to the stent, a lot of plaque burden with healed plaques and lipid-rich plaques. And LAD stent previously it was undersized. So that's the reason we have chosen DK cross stenting and covered the entire proximal portion of the LAD involving from the ostium to the previous. And because distal to the stent also there is a plaque burden that was also covered with the additional stent.
The other question from the online audience is, with that amount of metal work, what's the antiplatelet strategy going forward?
So we are giving a ticagrelor plus aspirin combination, standard DAP therapy. These patients definitely require minimum 1 year. If there is no contraindication, no high bleeding risk is there, where thrombotic tendency is there, we also extend beyond 1 year also. For these patients where there's a lot of plaque burden and recurrent stenosis, we are also giving a Repatha, like even we are giving a Repatha injections also.
And in addition, just a question from me, knowing how common re-stenosis is, will you restudy the patient?
All ISR patients compulsory, we do the re-stenosis, mainly to understand the mechanism. Is it because the neothrosphorus, is it lipid-rich edema, or calcified intima, or is it because of the fractures, or any missing link to if you are overlapping, if there is any miss is there, or any proximal edge atherosclerotic progression is there. So based upon that only, our previous stent is underexpanded. So we wanted to correct the underlying factors, then only we'll have the better results.
Sure. Sorry, my question was, will you look again?
Definitely, madam. Definitely we will look again during follow-up. After 3 months, again we restudy, because these patients come under high risk LAD and diagonal, should be followed up very carefully. And really, if symptoms are there, immediately we have to alert, and because this is a huge area, LAD diagonal.
Just a very small comment. I think DK crash for in-stent restenosis is not the ideal technique, because you have already metal inside, you are adding more metal, and you are not sure that will have complete expansion or good expansion, adding more and more metal inside. So I think, generally speaking, is not the ideal technique for me. For
here, this
in-stent restenosis.
Here, where we have stented, the crush was done proximal to the previous stent, not inside the previous stent, because the proximal to the previous stent, there is a diffuse atheroma. So that's the reason we have chosen. Suppose involving the previous stent, I would have not used the DK crush. The lesion is the entire LAD was diseased proximal to the previous stent. That's the reason we have chosen the DK crush.
Okay, just one remark. Sometimes less is more. So we have to agree that if you already had the stent that had an in-stent restenosis, a subtotal occlusion, then we can at least expect for the next 6 or 12 months or 2 years' time that maybe, even with the best drug-eluting stents, that you're going to encounter some recoil also, and also some restenosis. So sometimes the less is more. Maybe a drug-coated balloon, or maybe even doing kissing with a drug-coating balloon while stenting the main branch would have caused a bit less problem or less problematic intervention. That's just the first remark. Second, I think we always come back to DK crash or maybe double kiss culotte. I think culotte maybe would have been a better option here, could have caused less problems going through the diagonal branch, and even having less metal, because you crush one couple of layers. Maybe undersized balloon was done the first time, and then you went with the 3.5, which is probably the best option for the proximal LAD. But even then, you encountered some problems by recrossing both of the vessels. So I think in this particular patient, which you see that there's not a big of a difference with the vessel sizes of the diagonal and the LAD, I think you should even at least consider doing double kiss culotte, if we come back to double kiss technique, and then or even just doing the drug coating balloon intervention for the diagonal, because we can expect some more problems in 1 or 2 years' time. And then we also come back to the clopidogrel issue with a lot of metal inside those vessels, and which are the most important vessels for this particular patient.
Then the question is,
based on the even recent meta-analysis, DK crush scored over the crush Culotte. So based upon that, even ESC guidelines 2018 left main bifurcation. So they strongly, whenever we are using the bifurcation, preferable to choose the Culotte also.
I have to interrupt you. We have to go on with the next case. Thank you very much for the interesting case. I introduce Francesco Lavarra with this case on Culotte, the importance of pot.
Good afternoon, dear Chairman. Thank you very much for this kind invitation to present this case of complication at the EBC meeting 2021. The importance of pot in Culotte technique. This is a male with normal risk factor treated 4 months before on LAD diagonal with DK crash and proximal side optimization with the residual lesion on circ. This was the DK crash with PSO. The PSO is the immediate post-dilatation with a bigger non-compliant balloon of ostial side branch before the crash. This was the index procedure. The LAD diagonal at that time was good, and you see the lesion on circ and posterolateral. The operator decided to treat this lesion with a culotte, and this was probably the first wrong decision. Were wired both branches, pre-dilated, the OM, implanted a stent 2.514, then this was the result, rewiring from OM posterolateral. You see already with some difficulties, pre-dilated the posterolateral, and immediately implanted a stent on circ posterolateral. Then post-dilated only with the balloon used to pre-dilate extensively with quite good result up to this time. Then rewired the OM and opened the struts there with the same 2.5 balloon. And actually this is an enlargement to see the rewiring of posterolateral, and you see the operator had some difficulties. It was too fast, and in some way he rewired, he did a kissing with a bigger balloon, kind of very late pot with a 3.0 balloon there, and a very, very late pot then. And this was his result, but he had some doubt. The angio was not so good, and he did a stem boost, and the stem boost was ugly, terrible. So he did IVUS, and although the angio was not so bad, this showed multiple place where the stent was crushed, so the wire went in and out many times during the first rewiring or the second one. The so-called repair of the operator was done dilating extensively and crushing completely the malapposed stent, and then implanting another stent on the main branch. But this was not completely successful on repair what happened at the bifurcation and at the origin of the two side branch. You see the result also with another stem boost is ugly, terrible. In this same case, different stent techniques were used, one in a right way with PSO and decay crash on LAD, and one in a wrong way with a culotte without pot on LCXOM. To have a complication, as in flight accident, you need often more than one mistake. Most of the time, if short side branch lesion, one stent and provisional is the way to go. This case was definitely a one stent technique on circ, also for the angle of the two branches. Never be so sure distal or proximal stent in culotte to anchor to the wall and to have space for kissing and most for pot. The new DK culotte recommended also require the pot. Culotte is possible also when the diameter of the distal branches are different in the limit range of the maximal expansion of the stent used, but then is also more important, is essential, the pot before the rewiring. Intravascular imaging is very useful, most into stent technique, to avoid and recognize the possible pitfalls of the complex PCI. When there are more steps, it's more possible to do mistake, but it's most important to be able to use this imaging technique in a proper way. If you can use imaging in bifurcation, it's better to use from beginning. The stent boost can be used sometime in situation of lack of IVUS OCT, but also there the clinical judgment is more important. pot with a bigger balloon as a first step after stent implantation is essential in all bifurcation technique, but most in cases of double stent 1, like in DK crash, the PSO for side branch, especially to avoid rewiring problems. The final result, when not done in a proper way from beginning, is never perfect, and most of time completely unacceptable, most if you don't have huge experience. These steps, POT and PSO, make procedures safer and are essential. Thank you very much for your attention.
So, just to translate, I agree completely with Lavarra. Culotte is a provisional stenting. You go from the circ to the marginal, it's a provisional, but it's with two stents. So provisional, say, size the stent to the distal main vessel and then do the pot according to the proximal main vessel. So this is the rule. If you avoid this rule, then you go in this problem. We have all the tip and tricks, come back with the wire, pull back the wire, insert just to be in the, but at the end, if you have a well-opposed proximal main vessel, you have less of this problem. So this is true for Culotte. Provisional is the same for decay crash, so the pot is very important.
If I can say something, this is an unintended Culotte, but finally was only stented actually the main branch in a proper way, proximally and distally to the bifurcation. On the side branch, if you see in stent boost, is completely crushed, the stent, and there is a void in front of bifurcation. So actually the operator was scared to put the first stent there in the distal main branch, in the proximal main branch just in front of Carina. And actually, if I listened the presentation of Reno Virmani just before, and Akiko Meara, and also of Dr. Professor Greg Stone, and I think an experienced operator that did this procedure didn't do at the end big mistake. The patient now is in ticagrelor and will be called after other 3 months, so 6 months from second procedure, and we will see what we will do and we will find on this bifurcation. And remembering what you said just before in another case, probably there, if the main branch proximal is good enough and there is no big problem on side branch that has a short lesion there, the drug-eluting balloon could be an option if some problem happens.
I think there is a positive news. At least the operator realized that something was wrong. So I think I have to be humble.
Yeah. Otherwise, it was stent thrombosis for sure.
Yeah. So be positive.
Yes, was afraid that, but at the end because was afraid also to put the third layer of stent there. Yes.
So it's very important not only the IVUS, also the feeling with something that is not, completely free, and then you should use imaging, etc., etc.
Can I have
just
one comment? I think we all loved your remarks during this presentation, and I think the recognition of the problem, even with the stent boost, and after trying to solve that problem was excellent. And I think we all loved your take-home messages because they were so clear messages what to do and what not to do, and maybe less is more. So that congratulations for this case and the presentation also, and also we loved your remarks.
So thank you, Francesco. So we go on because we have not a lot of time. It's a pleasure to introduce Rony Matthew from India. This is interesting because we did, DK crash, Culotte. Now it's time for TMP problems, and this case is well documented by Rony Matthew with OCT, and very interesting case. So
Thank you for the invitation to present at the EBC 2021. The title of my presentation today is A Double Tap in Left Main Trifurcation, Triumphs and Tribulations. So this is my patient, a 65-year-old gentleman with an anterior wall MI 1 year back who underwent a primary angioplasty with a stent to the proximal LAD. And now he presents with effort angina. So if you see there's a lesion in the left main extending into the circumflex, ramus, and the LAD. It's a Medina 1111. The right coronary is normal. So to plan this angioplasty, we first did an OCT. And this is what the OCT showed us. The stent in the proximal LAD was underdeployed. And if you look at the area of confluence, there is a ruptured plaque there, which is healed with an area of 2.3 millimeters square. The left main had a calcific nodule with an area of 4.2 millimeters square. The 3D gave us a very important point, and that is the ostia of the circumflex and the ramus was a single ostia. And that was an important point. So for the bifurcation planning, the physiology showed us that the lesion in the left main was significant. It was 0.74 with IV adenosine. With the OCT, we got this information on the side branch that was a single ostia because the morphology, length, diameter decided. So what are the options we have? The simple option is to just go into an LM crossover, or to do a crossover and kiss, or to do a tap, a trifurcation tap, a double T with a trissing. Now, what's a trissing? Now, according to the dictionary, a trissing is to kiss two other people at once, or a three-person kiss. And that's what we thought we will do. So we started off with the left main LAD stent. We put a 3.533. We did a pot with a 4.5. And the result looked good. So we removed the jailed wire from the circumflex and the ramus, recrossed the circumflex and kissed it, sequentially recrossed the ramus and kissed it, and finally we did the trissing. So here we recrossed the circumflex with the balloon, and then we kissed that. Then we recrossed the ramus, and we kissed that with the left main, and then finally we do this trissing with 3 balloons, one for the left main to the LAD, to the circumflex, and to the ramus. But after this, we were not too happy with the result, as you can see over here. The lesion in the circumflex and the ramus remains. So we did an OCT at this point. And this is what the OCT showed. The 3D showed us there was a strut across the side branch ostia. Actually, you can see all the 3 wires here. The one wire going into the circumflex, the second wire going into the ramus, and this is the wire into the LAD. Somehow not satisfied with this result, we decided we're going to do a double tap. So now this is the double tap. A stent in the circumflex and a stent into the ramus. Deployed that, and again did the trissing. The result looked good, and I guess you would agree with me that the result looks good. And we thought we were going to finish it off with a pot. So we did the pot. The final result looked quite satisfying, and we thought we were going to come out with a final OCT. And this is what the OCT showed us. It's quite a surprise to us, because if you realize there's thrombus everywhere, and that's quite acutely. Right at the area of confluence, extensive thrombus. Into the left main, again extensive thrombus. And the 3D looks full of thrombus at the trifurcation point. The patient was clinically stable at this point of time. So we checked the ACT, and that was 340. But again, we gave heparin. The patient was on Plavix. So we changed it to ticagrelor, and we loaded him with 180 milligrams. We gave him tirofiban infusion. And now we kissed again. But we just did a kissing now. the left main and the circumflex. And as a result, we got patient remained stable. So we did another OCT. And thankfully, the thrombus is still there, but definitely less. And that's how the 3D looks. The ostium, the circumflex is open, the other ostium is full of thrombus. But because the patient remained stable, we continued the tyrosine infusion and shifted him to the CC. The next day, we took him back. Angio looked pretty decent. And we thought we were going to do another OCT at this point of time. So we did another OCT. And happy to note that the thrombus is much, much less. But it's still there. You can see the struts here of the tap. And this is what the 3D shows. You can see the struts of both the stents in the ostia. But since he remains stable, we decided that we're just going to continue him on aspirin and ticagrelor and discharged him. And everything seemed good. We got the results of the clopidogrel genotyping, and which showed that he was an intermediate metabolizer. So we continued him on ticagrelor. However, 2 years later, he came back, now with class 2 symptoms. And this is what the angio shows. We have got an ISR that's involving the ramus ostium and the circumflex. So what do you do at this point? We decided we're going to do another OCT. Now, this is what the OCT showed us. If you look at this view over here, you can see a lot of ingrowth into these struts, and this is how it looks at the area of confluence. A lot of neointimal growth at the strut, and the 3D shows neointimal growth. The entire ostia is divided into 2 particular ostia. So the take home from this is that trifurcation is a messy affair. You must use the minimal number of stents if feasible. There should be a low threshold for CABG, and an imaging is absolutely mandatory. Ticagrelor is always preferable because clopidogrel resistance is a reality. A routine PRU measurement should be done and know when to stop. And like in this case, I think a femoral approach makes life easy. Thank you all for your kind attention.
Thank you, Rony. It's a wonderful case and very clear, very well documented. My comment, this double TM protrusion is like a kissing stent in the left main. So you have, we know very well that there is neointimal hyperplasia at the follow-up. And the main reason to avoid this new carina and in this trifurcation is that if you try to treat again this patient, the risk is to close one of on the main vessel, so you have to send the patient to the surgery. So whenever, in my opinion, you have a trifurcation like this, you should consider the intermediate branch as a side branch and treat the circ as you suggest and the LAD, and then treat less aggressively the intermediate, maybe after the treatment of the circ. Less metal as possible.
To come back to the ostial circ is the Achilles heel of PCI. Even people like Ochai say that, you know, our Japanese CTO guru, and I think it's true. The other point is that ticagrelor is normally not, even as prasugrel, not 1A indication in stable patients. So normally we can't even use them in Switzerland because they're not reimbursed. So even if we think that it's better and safer because of resistance. So, and I think you were a bit lucky in this case because this case can go bad very quickly. And potentially I may have preferred cangrelor infusion instead of tirofiban in this setting. Because of course 180 of ticagrelor orally given doesn't make any sense in the first hours. So I'm sorry to be a bit rude.
Can I just say it's a great case, and we've all seen trifurcation and looked at it and thought we don't know what to do with it. And this just shows that it is dangerous to kiss more than one person at once, obviously. But I'd just like to ask the operator, at what point, if you went back and did it again, at what point would you stop? So it looked great after your left main to LAD stent, then instead of imaging, could you have pressure wired the other two branches? Or if you went back, when would you stop?
If I got another opportunity to do this case, I would probably just leave it with a provisional. With just a single stent into the left main LAD. I think we have learned with multiple times when we have done trifurcations like this, they generally always come back later with a restenosis at least of one of the vessels. And if you look at the myocardial mass that either the ramus or the circumflex subtends, I think it's a very strong take-home message that we should not be doing a trifurcation stenting. We should be either doing a provisional and decide to do a bifurcation and take one of the larger branches, maybe the circumflex, and in case you decide to do a two-stent strategy.
Do you think after you've done your main vessel stent, do you think the pressure wire of the other two vessels tells you anything? It might tell you if they're going to get angina straight away, but do you think it predicts that one of them's going to come back, or does it not tell us anything acutely?
I know we have data that has come from Kim with this paper saying that FFR would predict MACE, but I'm not too sure about that because I think the ostium of the circumflex is an entirely different animal. You know, you may see a pinch, but you have on OCT it looks oval, and I am not absolutely sure of the fact that an FFR would be the right answer.
Just a small comment. Just a short comment. When you do a pot in tap, be careful to be very proximal, because otherwise you risk to crash. And then if you do a crash in a double tap on Remus and Cirque is also more dangerous.
Just one more comment. Congratulations for the case, because this represents that maybe, as you suggested, the less is more issue. I think you try to do the TN protrusion technique, but somehow we get the feeling that it's always something very close to the technique that we don't use anymore, the simultaneous kissing stent, because you cannot avoid creating a neocarina, because there's too much metal in there, so that way it produces some more metal just being left in the left main. And that's why, as you suggested, I think probably, but we have gone through a couple of cases also, the straight vessels, the intermediate vessel, we always leave it like that. Maybe just do the drug-coated balloon or kissing with a drug-coated balloon, and have the most important vessels that supplies the most myocardial territory being treated. But treating this way, TN protrusion is a good option for this patient, but not for the intermediate. I think that was the potential problem causing issue. And then you had to go after the result, and congratulations for the procedure and the imaging that we could observe from this particular patient. But this leaves us the question that maybe we have to have less metal in the most important vessels.
Absolutely.
Yes, thank you. We have to go on. Thank you very much again, Rony. Dr. Sheiban will present the last case. It's a strategy in distal left main in an acute coronary syndrome patient with multivessel disease.
Dear Chairman, thank you for the invitation to present at EBC 2021. Today I'm sharing with you a challenging case of distal left main angioplasty in acute coronary syndrome patient with multivessel disease. 46-year-old male with multiple coronary risk factors. In January 2020, he had non-ST elevation myocardial infarction as first clinical manifestation, and he was admitted to another hospital with persisting chest pain started 20 minutes before his arrival to the hospital. He was stable. T-troponin was 470, creatinine was 0.9. Medical therapy was started with heparin, aspirin, nitrates, and beta blocker. Then he was transferred to our hospital for coronary angiography. He arrived with stable condition, chest pain was reduced, and he was dropped to cath lab. Angiography showed multivessel disease with chronic total occlusion of LAD, chronic total occlusion of right coronary artery, severe stenosis on proximal dominant circumflex, as the bifurcation with a huge marginal, which itself has a long lesion proximal segment, and severe stenosis on distal left main involving both LAD and circumflex. So syntax score was 41. Then complex anatomy with high syntax score, and first option in this patient should be surgery. But we have unexpected clinical evolution, since soon after angio and patient still in cath lab, chest pain was increasing with ST elevation now in inferolateral wall. We decided to proceed for angioplasty, and given the high-risk procedure, we selected the femoral access with 7 French guided catheter and contralateral femoral access 6 French, ready if needed for mechanical support. Soon after wiring the 3 branches, hemodynamic stability was deteriorating to cardiogenic shock, systolic blood pressure fall to 85, and oxygen saturation to 91%. Then we have 2 essential issues now around mechanical support, which and when, and angioplasty, only calculus lesion versus complete revascularization. We decided for mechanical support before proceeding, and angioplasty only to calculus lesion, that means left circumflex, marginal, and distal left main. So intra-aortic balloon was implanted, patient was intubated with anesthesiologist assistant. Then we proceeded to complete the procedure. We started from the bifurcation of proximal circumflex and marginal. So since it was complex procedure, we selected the dual stenting strategy, and that was modified T-stenting or reverse step, starting stenting on the marginal with a balloon in circumflex, then soon after stent delivery, kissing balloon inflation, then stent delivery in main vessel, and in this case, it was long stent covering the whole proximal segment of circumflex and crossing over to left main till the ostium. So completing also the stenting or provisional stenting on the distal left main bifurcation. Then we proceed to optimize the procedure with the pot in proximal circumflex and proximal left main, and then we recross to marginal and second kissing balloon inflation, and again proximal optimization on circumflex and on left main. After the pot in left main, we had total occlusion of LAD. Then we recrossed the stent to LAD and opening the strut with 2.5 balloon, and then completing the procedure with stenting proximal LAD prior to first diagonal with tap technique, which was optimized by kissing balloon inflation, and final pot with 5O balloon at 18 atmosphere in left main. And this was the final angiographic result. Soon after this procedure, hemodynamic stabilization was restored, ST elevation regression was obtained, spontaneous systolic blood pressure was 110, and intra-aortic balloon was kept 2-to-1 for 12 hours following the procedure. Intubation removed on the following day, that means 18 hours later. patient out of intensive care unit on second day with complete recovery and with no quite normal ejection fraction on echo that was 0.52, and hospitalization was free, and patient was discharged after 7 days with a planned second stage procedure for LAD and right coronary artery at 3 to 4 weeks later. But we have another surprise now. At nearly 1 month, patient was coming back for recurrent angina, and now angiography was showing tight stenosis on ostial left main. IVUS was taken and showed that there was no stent on ostial left main. There was only plaque with tight stenosis, and soon distally to this plaque, the stent was well opposed, well expanded, and not deformed. So this was treated with stenting on ostial left main with a short stent, 4.5 per 8 millimeters, deployed at 16 atmosphere, and post-expanded with non-compliant balloon 5.0 at 18 atmosphere. And this was the final result after proximal LAD, ostial left main stenting. Then we proceeded to complete the procedure for LAD recanalization, which was performed successfully by antegrade approach. The total occlusion was easily crossed with Gaia 2 wire. Then LAD was stented, and this was the result after LAD stenting. Then an IVUS was taken in order to check the previous procedure on both bifurcation on distal left main and circumflex. IVUS confirmed the optimal result. Everything was in place. Stent was well opposed and well expanded at all sides of both bifurcation. And finally, we completed the revascularization with another antegrade approach for total occlusion on right coronary artery, which was performed successfully during the same procedure. And now at 22 months follow-up, patients is still event-free. So my final regards that high-risk patients are not the ideal candidate for procedure, particularly in emergency settings. However, in some patients, PCI represents the only option to rescue the patient. The recommendation in this setting is to make it simple and fast as much as possible, and so to do what is necessary to restore hemodynamic stability in these patients. Left main ostial mist might be due to longitudinal stent crushing by guiding catheter or stent shortening with overexpansion of inappropriately sized stent. Unexpected complication might occur despite the experience and the meticulous work of the operator. Thank you very much for your attention.
So you're very late because the next session is in 20 minutes. But it says you explain everything. I think that the most important point from the technical point of view was the geographical miss of the follow-up. So there is theory that proposed in the past to go always to the ostium because you had the same.
Actually, I think it is a very important point. Particularly with some stents like Onyx in this case.
Yeah, with the less links,
yeah.
You
cannot expand 3.5 with 5 balloon because you will have shortening of the stent. This is I documented this in many other procedures. That mean, but in this situation we were on emergency. We have to rescue the life of the patient. Then. You cannot do IVUS before, you cannot do anything. You have just to work and to restore blood flow.
What is surprising is that the patient survives with counterpulsation only because it's a poor support. In this case, Impella, but I'm surprised, and it worked fine.
Actually, yeah, Impella was more appropriate maybe, but in the cath lab, in that moment, we had ready the intra-aortic balloon.
No,
that was the reason for that. I totally agree with you.
Another suggestion, sometimes when we have this patient, before discharge the patient, to put the patient on the table and evaluate with IVUS if they need, because he had to complete the revascularization, but it was left main, just to be sure that everything was okay. Is an option not to do immediately, but after a few days, just to guarantee that it's okay. Thank you very much.